Welcome back. Now I would like to discuss an algorithm that was developed by Mount Sinai Hospital. And I will show you the rationale of how they use medications. Obviously, this is not evidence-based and it's not confirmed through randomized trials. So again, this is in the phase of trying the best you can when you're desperate. But let's see how they thought about the process in Mount Sinai. Well, here's a patient that comes in with symptoms of COVID. And you test the patient tests positive, and you ask yourself, am I worried about the patient? Because if you're not worried about the patient has certain symptoms and maybe findings on a chest x-ray, but the patient is stable enough, not hypoxemic enough, then I'm going to support the patient. Treat their fever, their cough, and give them supportive care. But if I am worried about the patient, and there are two scenarios here, either the patient looks okay, but I know this is the patient who can develop complications because the patient is older than 60, patient is obese, the patient has chronic disease, cardiopulmonary issues, the patient is immunocompromised. This is the patient that they decided at Mount Sinai, even if the patient looks fine, I'm going to treat. Okay, they committed the patient to treatment with what? Atazanavir and hydroxychloroquine. Why did they come up with that regimen? I don't know, but that's what they decided. That's, again, as of late March. So one way that makes you worry about the patient is that the patient himself or history of the patient is not good. This patient has comorbidities, and I'll worry, even if he looks okay. The other scenario is the patient is not that old and doesn't have the comorbidities, but he doesn't look good. Meaning what? Meaning he's not able to keep his saturation above 93% on room air. That's a hypoxic patient. So we decide what? We're going to treat that patient. So the two scenarios, either the patient has comorbidities that makes you worry, or the patient is not looking, pretty hot, desaturating early on, and that makes you commit the patient to that arm of treatment. And then you're going to follow the patient. If you realize that the patient is requiring more than 3 liters of oxygen flow to maintain his saturation, then that's the patient who is deteriorating. And that's a patient who needs to be on the right side of the screen, which is the treatment of severe COVID pneumonia. Obviously, you're going to try to follow the guidelines here that they put in terms of laboratory analysis. They advocate the check of inflammatory markers, including the CRP, the procalcitonin, ferritin, LDH, troponin, D-dimers, fibrinogen, PT, PTG. I know that that's a lot to ask for hospitals with limited resources, and I know this is very pertinent when I speak to audience in Egypt. They also advocate that you do one-time test of like HIV status. They're trying to find out if the patient is immunocompromised or not, and then you follow for cytokine panels. If the cytokine panel is totally elevated, then maybe you want to consider tocilizumab. If the patient is moving into the severe category, meaning what? Meaning that I give the patient oxygen, 3 liters. He requires more than 3 liters to maintain his oxygenation. Then that's a patient who is going to require additional medications, additional therapy. So they say at that time, consider giving the patient 1 dose of tocilizumab. And some people will advocate checking IL-6 level before you do that. But anyway, tocilizumab 1 dose because the medicine will last a long time. It has a long half-life. And then talk to your ID colleagues about even considering remdesivir for that patient. And your ID colleague is going to ask you all these questions to see if the patient is qualified for the medicine. Some of the reasons that medicine could be denied is, number one, if the patient has multi-organ failure, that's kind of late in the disease. If we already damaged many organs, remdesivir, which reduces the replication of the virus, is not going to really help you. We need to use it at an earlier stage. If the patient is dependent on vasoactive medications to maintain hemodynamics, again, that's a patient who's kind of late in the process. If the patient has liver damage with increased ALT more than 5-folds the upper limit of normal, then remdesivir is not good for these patients because, again, of the hepatic toxicity. If the patient is on hemodialysis or if the creatinine clearance is less than 30, then that's not a good candidate for remdesivir. Now, if the patient had been on treatment with other medications like hydroxychloroquine in this case, but as long as you stop the medications before you start remdesivir, that's okay. So that's not an exclusion criteria. We're not going to say, oh, because you've been on hydroxychloroquine, now you're not a candidate for remdesivir. That's not a contraindication. As long as you stop those medications before you administer remdesivir. Okay, I hope that kind of summary helps you. Again, that's the way they thought about it at Mount Sinai. I'm not saying that this is the perfect solution, but this is one regimen that is not evidence based. Other institutions also came up with their own regimens in terms of what labs to draw, what therapy to commit the patients to. This is Mass General, and I don't have to repeat every protocol, but you just get the idea. This is University of Washington, one of the very reputable, famous places in the U.S., and it looks like most of the therapy was hydroxychloroquine based as well. Now, I need to address management of asthma in the COVID era. If the patient tested positive for COVID, but he also have exacerbation of his asthma, what do you do? I'll tell you one thing, just to summarize the whole management thing. Treat the asthma, ignore the COVID status. Forget that the patient has COVID. If the patient has asthma exacerbation and he needs his medications, administer the medications. But we're going to talk about how to be smart about administering the medications. For example, if you have to administer a bronchodilator, don't use the nebulizer technique because, again, with nebulization, there is aerosolization and there is a chance of infecting everybody around. So rather use the MDIs in a closed system with a spacer. Now put the spacer tightly on the nose and the mouth. Spray the medicine into the spacer, and the patient can inhale from within the spacer. Of course, don't use the spacer on multiple patients. This is a no-brainer. So no nebulization, but MDIs. Closed system rather than open systems. Now, if the patient needs steroids for the asthma exacerbation, then use the steroids. If the patient has severe allergic rhinitis and you need to use corticosteroid nasal sprays, use them. So Gina is saying basically treat asthma as you would in a patient who does not have COVID-19. Let me see if there is anything else that we left out. We talked about MDIs rather than nebulizers, allergic rhinitis, we addressed it. If the patient had been on long-term oral corticosteroids and you need to continue them, there is no contraindication, but try to use the smallest dose possible. So these are the recommendations from Gina. Prognosis of COVID pneumonia ARDS. As you saw globally, there's 50% fatality when we talk about the global level and even in the U.S. But once the patient deteriorates and reaches the level of ARDS and get on the vent, unfortunately, mortality had been very high, between 50 and 70%. So those patients who get on the mechanical ventilators, especially when they have multi-organ damages, they don't do very well. Use of antibiotics. When patients get COVID, they are not immune from getting other infections. There could be co-infections. And when the patient had been on the ventilator for 3, 4, 5 days, they can develop that. So be vigilant and watch their sputum secretions, send cultures, and check for bacteria and any other infections that might coexist. Some patients have co-infections with different viruses. RSV could be a co-infection with COVID. Certainly examine them and swap them for pneumonia, influenza A and B. So the use of antibiotics, if proven by cultures, then absolutely valid. But what about starting empiric antibiotics? Again, that depends on your level of suspicion of bacterial infection. If the procalcitonin initially is negative and that is consistent with a viral disease, and then in a couple of days it turns positive, that is actually a poor prognostic sign, because it means that there is now co-infection with bacteria, and that's a perfect time to start your antibiotics. I personally start empiric antibiotics on patients. I don't want to take a chance. And then I send the cultures, and within 48 hours, if the procalcitonin is still negative and the cultures are negative, then I might stop the antibiotics. Experimental drugs. We already addressed hydroxychloroquine in the guidelines, or the recommendations at least, and we saw that people are leaning towards more use of hydroxychloroquine in patients with COVID pneumonia. Now, these are studies that were done in China just to see the effectiveness of those medications. As you can see, this is chloroquine effectively reduced the viral loads in vitro. A second study also out of China, an open label, non randomized clinical trial on hydroxychloroquine. The number is small, 20 patients and like 16 controls. But again, you still see the effect in the arm of hydroxychloroquine. And here, hydroxychloroquine azithromycin combination. So again, more evidence compiling towards the use of hydroxychloroquine. We cannot say that the evidence is final or proven yet, but there is maybe a tendency towards the use of hydroxychloroquine, hoping that patients will do better. Again, as you can see, symptomatology improved with the use of hydroxychloroquine in these studies. Anticoagulation, that's one of the good questions that came out. And obviously, I'm aware of one autopsy that was done on a COVID ARDS patient who died. Obviously, autopsy is a high-risk procedure that can aerosolize the virus, and now even the burial technique had been modified to make sure we don't infect the funeral home workers and stuff. But they did find microvascular coagulopathy and clot formation in the small vessels in these patients. Whether you believe it's secondary to hydroxychloroquine use that induced hypercoagulable state, or whether it's the viral infection itself. Anyway, how do you handle that? We routinely use prophylactic anticoagulation. And there is a table now, an algorithm, hopefully I can show it to you, of escalating doses of low molecular weight heparin according to the patient's weight and severity of illness. So the heavier the patient, you would use higher doses of low molecular weight heparin, starting at 40 up to 120 milligrams per day. So yes, we advocate the use of prophylactic anticoagulants. I'm not aware of anyone who used systemic anticoagulation for those studies. So no one is advocating the use of intravenous heparin at this point. If the patient has renal failure, then you would follow the same guidelines and put the patient on heparin, unfunctionated heparin, rather than low molecular weight heparin. Now, who would benefit? I would think that the patients who have the highest D-dimers are the ones who are at increased risk of developing the coagulopathic complications. So patients who have D-dimers more than 3 microgram per ml are the ones that I would advocate the use of subcutaneous heparin in even higher dose. Now, angiotensin II. Now, there had been a debate about the angiotensin receptor, and we think it's a gate through which the virus can gain access intracellularly. And initially, people were concerned about administering AC inhibitors, and they said, well, that might actually increase the representation of the receptors. And now other people said, no, let's use AC inhibitors, because if you block all the receptors, then the virus has no port of entry into the cells. And actually, there is a study ongoing now at UCSD using ramipril to see the effect of ramipril on suppressing the viral entry into the cells. The clinical trials that are ongoing to UCSD, I will give you like a little bite on all the studies that are ongoing. I have the full description of the studies, and like I said, we were talking about them this morning on Grand Rounds. One of the things that is exciting everybody, and there is an ongoing trial at UCSD as well, on the use of convalescent plasma or serum from patients who had the virus and recovered. 5 donors, it's a small number, 5 donors confirmed to have the disease, and then they turned negative, and we collected their antibodies, and they had good neutralizing level of antibodies. The recipients were, again, 5, received about 400 cc's of plasma. They were confirmed to have COVID disease, and the PF ratio was less than 300, so they were, sick. The study claims that 3 of them cleared the virus within 3 days, and then the fever curve dropped and the PF ratio improved. So we'll see what the bigger number study show us. So the authors of that study are advocating for the use of convalescent plasma. Question is, are we going to have enough plasma for everybody to go around? We will see. I'll stop here, and I will see you in the next bite.